Welcome back to my channel. If you are visiting this space for the first time, you are also highly welcome. In this lecture, we'll be looking at the rectum. The rectum is the region of the gastrointestinal tract that is located between the sigmoid colon superiorly and the anal canal inferiorly. This is the sigmoid colon here, arrowed in yellow, and inferiorly we have the anal canal that is also arrowed here in yellow. In between these two structures is where we have the rectum, and this is the rectum. The rectum is about 12 centimeters in length. Going to the functions of the rectum. The rectum plays significant role in defecation. When stool or physics enters into the rectal ampulla, which is the expanded distal region of the rectum, where we have stretch receptor. This we say signal to the central nervous system, which will help to initiate or delay the process of defecation. So if we decide to defecate, the process is going to be allowed. And if we decide to do otherwise by delaying it, maybe we've not gotten to a region where that can be done, the process will be delayed. And all this will be controlled by the central nervous system through the stretch receptors that are located in the wall of the rectum. So driving more on the rectum is a straight tube, but it is curved. So it tends to present a number of curvature along its borders. And this is the rectum here that is seen to be curved. So along its anterior-posterior alignment, it is seen to present two curves. And this includes the sacral flexure, and this is the sacral flexure. You can see this flexure that is created by the rectum where it aligns with the sacral bone. And this is the region that is marked in yellow. And after this flexure, another flexure is seen, and this is referred to as the perineal flexure or the anorectal flexure. And this is the region that is highlighted here in red. So you see a curvature at the upper part that aligns with the sacral bone. And after that, you see another curvature that tends to be created inferior to that. And this is referred to as the perineal or the anorectal flexure. So this is the region here. So those are the flexures that are created along the anterior posterior alignment of the rectum. The perineal or anorectal flexure here that is marked in red is the terminal region of the rectum, and this is where it turns posteriorly to become the anal canal. This is the anal canal here. You can see that the anal canal is directed posteriorly. It also presents another curvature at its lateral wall, and these are referred to as the lateral cuffs. And these are seen along the lateral border. So if you view the lateral border of the rectum, you also see it to present lateral curvatures. And these are 3 in number. And these include the upper right flexure, and this is the upper right flexure. After this, we have the middle left flexure, and this is the middle left flexure. And more inferior to that, we have the lower right flexure, and this is the lower right flexure. And these are referred to as the lateral cuffs. So it is good for us to be able to establish these curves that are created around the wall of the rectum. So now you can see that even if the rectum is projected as a straight tube that is formed after the sigmoid colon, so you can see the number of curvatures that we've highlighted using this slide. So going further on the orientation of the rectum, where does the rectum begin from? The rectum begins from the level of the third sacral vertebra. So this is where it begins from. And this image here, this is where it begins from, just inferior to the sigmoid colon. Also tallies with the level of the third sacral vertebral bone. If you look at the transition between the sigmoid colon and also the rectum, you see that there are a number of differences. In the sigmoid colon, we have infolding seen along the wall of the sigmoid colon. We have the tinea coli also running through its entire length. And on both sides of the tinea coli, we have epiploic appendages. This kind of presentation is also seen in other regions of the large intestine. But in the rectum, this is not seen. If you look at the wall of the rectum, there is no tinea coli. And if there is no tinea coli running through its length, it means there is not going to be the formation of infoldings, which are called the ostration or circulation created in the wall of the large intestine. And there will not still be the deposit of fatty tags, since we do not have tinea coli running through its wall. And because fatty tags are deposits on both sides of the tinea coli, and since there are no tinea coli, there will not be fatty tag deposition. So in the wall of the rectum, there is no tinea coli, there is no ostration, and there is no epiploic appendages. It's also good for us to note this, So going more on the orientation, we've tried to establish where it begins from, and that is at the level of the third sacral vertebra. And of course, it will terminate at the anorectal junction, and that is the junction where it continues to become the anal canal. And this is the point marked here in yellow, and this tallies with the tip of the coccyx. This is the coccyx here, which is the terminal region of the vertebral column. Posteriorly, it corresponds with the tip of the coccyx, while anteriorly it corresponds with the apex of the prostate gland in male. This is the prostate gland here, and the apex, of course, harrowed in red. So anteriorly, it corresponds to the apex of the prostate gland in male, while in female, posteriorly, it corresponds with the tip of the coccyx as seen in male, while on the anterior part, it tallies with the lower quarter of the vaginal canal. Because the uterus is what is seen as an anterior relation of the rectum in female, and we know that the uterus is continuous inferiorly, has the cervix and also the vaginal canal. So this is why we have the lower part of the vaginal canal as the inferior limit of the rectum in female. We'll also get to this as we go through with this lecture, just for us to know that in female, the inferior border of the rectum is marked by the lower quarter of the vaginal canal. This is because of the position of the uterus that is seen to be located anterior to the rectum in female. So that is what is established where the rectum terminates in both the male and the female. And if you see the configuration of the rectum, looking at this image down here, you see that at the point where it continues to become the anal canal, there is an angulature that is created at that point, and this is called the anorectal angle. The anorectal angle is the angle that is created at the point where the rectum becomes the anal canal. So this angle, as you can see, is directed posteriorly. And if you look at this image up here, this is the anorectal angle, which marks the border between the rectum and also the anal canal. You can see that the anal canal is directed posteriorly. And this is the region here. This is the angulature that is created here, marked in blue. So this angle tends to widen or increase so as to allow the process of defecation. So during the process of defecation, there's going to be an increase of this angle marked in blue. And when it increases, it means that the anal canal will be more straightened because of the increase in this angle that is created by the anorectal junction. So the increase of this angle will help to facilitate the process of defecation. Because the anal canal is directed posteriorly, if there is an increase in the anorectal angle, it means this angle will be less curved. So the anal canal will be straightened to some extent so as to allow the easy passage of the physics. Also to add, the anorectal junction is being held onto the posterior wall of the pubic bone by the puborectalis. This is the puborectalis here, arrowed in black. This muscle act like a sling around the anorectal junction and thereby giving it a structural support or helping to hold the anorectal junction to the posterior border of the pubic bone. The pubic bone is one of the bones that form the pelvic bone. Also, during the process of defecation, this puborectalis muscle also acts as a support with the external and internal anal sphincter to help facilitate the process of defecation. So talking about anterior connections of the rectum, there are specific structures that are seen to be connected to the rectum anteriorly. The structures that are related anteriorly to the rectum in both the male and the female are different. So also the structures that are seen to be connected to the rectum in both the male and the female will be seen to be different. For the male, we have the rectovesical pouch. We have tried to establish on this channel that when we see name composites, all we need to do is to break the name down. So breaking this name down, it means the pouch that is created between the rectum and also the urinary bladder. The urinary bladder is the vesicle. So this is the rectovesical pouch. And this is an anterior reflection of peritoneum that is seen from the rectum connecting to the urinary bladder. This is what is harrowed here in yellow. This is the urinary bladder here, and posteriorly we have the rectum. So the rectovesical pouch is helping to connect the urinary bladder to the rectum. Also going further on the rectovesical pouch, there is an inferior extension of this pouch And this is the inferior extension of this pouch, also arrowed in yellow. This inferior extension is referred to as the rectoprostatic fascia or the denovillus fascia. All we still need to do is to break the name down, rectoprostatic fascia. It means the fascia that is seen between the rectum and also the prostate gland. We know that the prostate gland is seen to be located at the inferior part of the urinary bladder. This is the urinary bladder, and this is the prostate gland here that is highlighted in blue. This extension from the rectovesical pouch that is referred to as the denovillus fascia or the rectoprostatic fascia is seen to border or separate the prostate gland from the rectum. And what this does is to prevent the posterior spread of prostate cancer. So in case of prostate cancer, this will be like a guide or a barricade that will help to prevent the spread of prostate cancer to structures that are located posterior to the prostate, and this will include the rectum. So this is also good for us to highlight as part of the structures that are located around the rectum. Now going to the structure that is connected anteriorly to the rectum in female. So for the female, we have the rectouterine pouch. The rectouterine pouch, all we still need to do is to break the name down, rectouterine. So it means the pouch that is created between the rectum posteriorly and also the uterus anteriorly. So this is the rectouterine pouch. We know that in the female, we have the uterus. We do not have uterus in male. So the uterus is located between the urinary bladder anteriorly and the rectum posteriorly. Unlike in the male, where we have the urinary bladder located anteriorly to the rectum. In the female, the uterus is located in between the urinary bladder anteriorly and also the rectum posteriorly. And that is why we have the rectouterine pouch as an anterior reflection of peritoneum connecting the rectum to the uterus. Now we can see the differences in the structures that are connected to the rectum anteriorly in both the male and the female. This is as a result of the organs that are located anterior to them. In both the male and the female, the organs that are located anterior to the rectum are different. They are not the same. And that is why we have different named pouches related to the rectum anteriorly in both the male and the female. So going further on the wall of the rectum, we have the rectal ampulla. This is the rectal ampulla arrowed here in black. The rectal ampulla is an expanded or dilated inferior portion of the rectum. And this region is created for the storage of physics. We said that in this region, we have a number of stretch receptors that help to send stimuli to the central nervous system for it to initiate or delay the process of defecation. So it depends on the situation at hand. It will help to either initiate it or delay it depending on the circumstance. Anorectal ring is a palpable muscular ring that is formed by the puborectalis and also the anal sphincter. This is where we have the anorectal ring created. It's just a thickening of muscular band that is created by the puborectalis muscle in association with the anal sphincters. So you feel a thickened muscular band around the wall here that is formed by these structures. So going further on the interior wall of the interior wall of the rectum is segmented because of the rectal valves of Easton created within the internal wall of the rectum. And this had 3 sickle cell shaped horizontal fold that tends to deepen into the circular muscle of the rectum. Considering the formation of other valves that are created, which are just mere thickening of the mucosal lining, for the rectal valve of Easton, this thickening extends to the circular muscular layer of the rectum. So it presents a pronounced thickened configuration within the internal wall of the rectum. And these are 3 in number. We have the upper rectal valve of Easton. This is the upper rectal valve of Easton at the upper part. And this is followed with the middle rectal valve of Easton, which is also arrowed in black. And finally, we have the lower rectal valve of Easton. These valves basically are horizontal thickened muscular bands that are created within the internal wall of the rectum. This is to help control the passage of physics along the lumen of the rectum. We should also know that the middle rectal valve of Easton is the largest out of all the three rectal valve of Easton that are created within the internal wall of the rectum. The level of the middle rectal valve of Easton also corresponds to the region of the rectovesical pouch and also the rectouterine pouch. At the level of the middle rectal valve of Easton is where these pouches are created in both the male and the female. It's good for us to know this in case we are asked during exam that the rectovesical pouch or the rectouterine pouch corresponds to what level of the rectal valve of Easton. So it's good for us to take note of this. So going further, we know that the rectum is generally classified as a retroperitoneal organ because it is not seen to be enclosed entirely by peritoneum, and that is why it is classified as a retroperitoneal organ. But we would be doing justice to the peritoneal relation of the rectum in details using this slide. If you try to divide the rectum into three equal parts, we have the proximal third, we have the middle third, and we have the inferior third or the distal third. All these regions are related to peritoneum in specific patterns, and this will be unfolding using this slide. For the proximal 1/3, it is lined by peritoneum on both the anterior and lateral surfaces. And this is the kind of presentation that is seen. Let's say this is the wall of the rectum highlighted in blue, and the peritoneum is seen to line the anterior and also the lateral surfaces. And this is what is presented in the proximal 1/3 of the rectum. This kind of configuration is classified as a secondary retroperitoneal presentation. A specific form of retroperitoneal presentation in the middle third is a different scenario. The peritoneum is seen to line just the anterior surface. And let's say this is the wall of the rectum, also highlighted in blue. So you see the peritoneum running through the anterior surface at this region. While the distal 1/3 is not seen to present peritoneal relation because it is seen to be located below the level of peritoneal reflection. Let's say this is the wall of the rectum. So we do not see any form of relationship created between the peritoneum and also the rectum in the distal 1/3 because it is seen to be located below the level of peritoneal reflection. So no contact with peritoneum at this region. So this is the kind of presentation that the different regions of the rectum is seen to present when it comes to peritoneal relations. So we see that generally it is classified as a retroperitoneal organ because it is not saying that the entire surface of the rectum is covered by peritoneum. So it's good for us to be able to establish the different relations with the different subregions. Even though we have highlighted that the rectum is a retroperitoneal organ, it is also seen to present some form of covering. So it is not structurally seen as what is presented in other form of mesentery. So let's try and dive into this. So we have the wall of the rectum lined by connective and fatty tissue. And of course, this is then enveloped by a fascia that is called the rectal fascia. So look, using this image here, the region that is marked in black at the central part is the wall of the rectum. And outside this region, we have connective tissue, we have fatty tissue, and these tissues are embedded with vessels. And that is why we have this presentation here. Also highlighted in red, blue, and also in black. So you see that within this tissue that is seen to encircle the wall of the rectum, we have vessels that are also embedded within it. So this is the outer configuration of connective tissue and also fatty tissue that is embedded with vessels. So outside this fatty tissue, we now have the rectal fascia that is arrowed in black. So you can see that the rectum on the inside is padded by connective and fatty tissue, which are embedded with vessels. And this is then further enclosed with a fascia that is called the rectal fascia. And this kind of configuration is what the surgeon sees as mesentery, and that is why it is referred to as the mesorectum. The mesorectum is a membrane-bound structure that is seen to surround the wall of the rectum. Even though it has been classified as a retroperitoneal organ, because it is seen with this kind of structural configuration, this is then taken as the mesorectum. So going further, we have the presacral fascia. Just from the name, is a fascia that is seen to line the anterior aspect of the sacrum. This is also seen to enclose sacral vessels and nerves. So this is the sacral bone. We know that the sacral bone is the inferior extension of the vertebral bone, after which we have the coccyx. So anterior to the sacral bone, we have the presacral fascia. This is arrowed here in white. It's just the fascia that is seen in the anterior border of the sacrum. just as the name implies, pre-sacral fascia. And this fascia is seen to enclose the sacral vessels and also the sacral nerve. And this is what is highlighted here in red and also black, just seen posterior to the pre-sacral fascia. So this kind of configuration is what is seen at the posterior part of the rectum. And this is the rectum. And of course, we say that the rectum is encircled by the rectal fascia. And this is what is presented around the space. You can see this region here. This is the rectal fascia. And the rectal fascia, of course, encloses connective tissue and fatty tissue around the rectum. So what we see now is a space created between the mesorectum and also the presacral fascia. Remember, we have a presacral fascia here, arrowed in white, and we have the rectal fascia here also at the front. So we have a space created in between these two structures, and this space is called the retrorectal space or the presacral space. Retrorectal means it's behind the rectum, and presacral means it is anterior to the sacral bone, just as the name implies. So this space is seen to separate the mesorectum anteriorly and the presacral fascia posteriorly. And what is contained within this space are loose areolar tissue and also connective tissue. There are no vessels seen to be present within this space, and that is why it is an avascular region that is safe during surgery. And also it creates a potential space for tumor of the rectum to extend into. So let's look at the Waldeus fascia. The Waldeus fascia is also an interesting part of structures that are located behind the rectum. Remember, we already established that we have a space that is called the retrorectal space or the presacral space. This space is what is highlighted in black, and it's created between the mesorectum and also the presacral fascia. You see that within this space, we have the Waldeus fascia, which is also referred to as the rectosacral fascia. Just from the name, it means a fascia that links the mesorectum with the presacral fascia. So you see it's connecting the mesorectum with the presacral fascia. So this is the Waldeus fascia that is harrowed here in red. And what it does is like helping to divide the retrorectal space or the presacral space into the superior and the inferior compartments. All these structures that we have highlighted at the posterior region of the rectum are important landmarks during surgery. So let's try and drive more on the anterior relations of the rectum. Structures that are related anteriorly to the rectum in both the male and the female are not the same because of the peculiarity of the reproductive system. For the male, we have the coil of the small intestine. This is the coil of the small intestine here highlighted in red, and you see it as an anterior relation of the rectum. This is the rectum located here. We also have the rectovesical pouch. This is the rectovesical pouch. We already established this pouch in our previous slide as an anterior reflection of peritoneum connecting the rectum to the urinary bladder in male. Then we have the fundus or the base of the urinary bladder. We already know that the urinary bladder is located anterior to the rectum in male. So we have the base or the fundus of the urinary bladder. Then we have the terminal region of the ureter. This is the ureter. So the terminal part where it enters into the urinary bladder is also seen as anterior relation of the rectum. We have the prostate gland. This is the prostate gland here highlighted in blue. And this is seen at the inferior part of the urinary bladder. And this also forms one of the structures that are related to the rectum anteriorly. Then we have the seminal vesicle. This is seminal vesicle here highlighted in yellow. Seminal vesicle is one of the accessory glands of the male reproductive system, and it's also seen to be located anterior to the rectum. Then we have the vas deferens. This is the vas deferens highlighted in white. The vas deferens carries sperm that is produced in the testes. It forms the anterior relation of the rectum. Then we have the denovillus fascia. We already talked about this fascia in our previous slide, which is an inferior extension of the rectovesical pouch that tends to separate or demarcate the prostate gland from the rectum. This also is seen in the anterior part of the rectum. So these are the structures that are related anteriorly to the rectum in male. So going further on the female, because we have different structures that will be relating anteriorly to the rectum in female. So one of the structures, the coils of the small intestine, just as we have in the male, and this is highlighted in red. Then we have the rectouterine pouch, which is the anterior reflection of peritoneum that connects the rectum with the uterus. And this is what is arrowed here in blue. Then we have the body of the uterus, and this is the body of the uterus arrowed here in black. We said that in the female, the uterus is located between the urinary bladder and the rectum. Then we have the cervix. The cervix is the inferior part of the uterus. So this is the cervix. Then we have the vaginal canal. So those are the structures that are related anteriorly to the rectum in female. You can see that there are differences in terms of anterior relations of the rectum in both the male and the female. So going further on the posterior relations, for the posterior relations in both the male and the female are the same, because the reproductive organs that are located within the pelvic cavity are not seen to be located behind the rectum. They are only seen to be located anterior to the rectum, and that is why we have differences in the anterior relations of the rectum. But for the posterior relations, the organs are not there, so the structures that are related posteriorly to the rectum in both the male and the female are the same. And the first structure will be the bone. We have the lower three sacral vertebrae, which include the S3, S4, and S5. Remember, we said that the rectum begins at the level of the third sacral vertebra. So the vertebra at this level and the ones that are inferior to it will be what is related to the rectum posteriorly. We also have the coccyx. So this is the sacral vertebrae arrowed in black, and we have the coccyx here inferior to it arrowed in white. So these are the two bones that are related posteriorly to the rectum. Then another structure, we have the median and the lateral sacral arteries. We know that we have the abdominal aorta. This is the abdominal aorta that bifurcates into the common iliac artery. The common iliac artery will then further divide into the external iliac and the internal iliac. So this is the external iliac and this is the internal iliac. From the internal iliac, we have the lateral sacral artery. So this is the lateral sacral artery emerging here. And of course, this is seen at the posterior part of the rectum. Then we have the median sacral artery. And this is the medial sacral artery that emerges just at the point where the abdominal aorta bifurcates. You see it also as a posterior relation of the rectum. And we also have a corresponding named vein. So we have the median sacral vein and we have the lateral sacral vein also seen at this space. Hence, they form the posterior relations also of the rectum. Then we have the sacrosympathetic chain. This is the sacrosympathetic chain highlighted here in white. It's a bilateral sympathetic network of nerve that is created also at the posterior part of the rectum. Then we have the lower sacral nerves. The lower sacral nerves will be from S3, S4, and S5. Remember, we said that the rectum begins at the level of the third sacral vertebra. So this is one of the sacral nerves departing through the anterior sacral foramen. This is the anterior sacral foramen through which the sacral nerve will pass through to be positioned at the posterior part of the rectum. So the nerves that are seen at the posterior part of the rectum, in the case of tumor of the rectum is going to press on this vessel. And because these nerves innervate structures in the lower limb, there's going to be pain in the lower limb because of the compression of the rectum that is created as a result of the tumor. So it's good for us to be able to justify this. So going to the blood supply of the rectum, this rectum is supplied by 3 vessels, and the main arterial supply is from the superior rectal artery. The superior rectal artery is the branch of the inferior mesenteric artery. This is the abdominal aorta, and we know that in the anterior part of the abdominal aorta, we have the emergence of the inferior mesenteric artery. This is the inferior mesenteric artery, also arrowed here in black, that emerges at the anterior part of the abdominal aorta, just inferior to the emergence of the superior mesenteric artery. I've also done a lecture on the superior and the inferior mesenteric artery. Kindly please go and check this up. So we have the inferior mesenteric artery, and this will then give rise to the superior rectal artery. And this is where the chief supply of the rectum comes from. The rectum also receives blood supply from the middle rectal artery and also the inferior rectal artery. So the middle rectal artery is a branch of the internal iliac artery, while the inferior rectal artery is a branch of the internal pudendal artery, which also branches from the internal iliac artery. So this is the middle rectal artery arrowed in yellow, and this is the inferior rectal artery arrowed in red. The middle rectal artery is branched from the internal iliac artery, and this is the internal iliac artery here, arrowed in white. And the inferior rectal artery is from the internal pudendal artery, and this is the internal pudendal artery that is arrowed in blue. The internal pudendal artery is a branch from the internal iliac, and this is the internal iliac also arrowed in white. We know that the internal iliac is branched from the common iliac. The common iliac artery is from the bifurcation of the abdominal aorta at this point. That is where we have the branches that supplies the wall of the rectum. Also going to the venous drainage. For the venous drainage is a different ball game. So we have two plexuses form on the wall of the rectum. We have the internal rectal venous plexus or the internal hemorrhoidal plexus, and we also have the external rectal venous plexus or the external hemorrhoidal plexus. These two plexuses are seen on the wall of the rectum, though are located on different layers or different regions on the wall of the rectum. So these two plexuses are created on the wall of the rectum. One is on the inside as the name describes, and the other is on the outside as the name describes. For the internal rectal venous plexus, this is the internal rectal venous plexus. It is seen within the submucosal layer of the rectum. So it is seen at the internal wall of the rectum, and that is why the name is so created. And we have the external rectal venous plexus on the outside that is seen on the external surface. And this is seen outside the muscular layer of the rectum, just as the name implies. So these plexuses are then further drained into the superior rectal vein, the middle rectal vein, and also the inferior rectal vein. So these veins are what finally collects the venous drainage of the rectum. So for the superior rectal vein, this is the superior rectal vein that is harrowed here in red. This is the middle rectal vein, and this is the inferior rectal vein. For the superior rectal vein, the venous blood is collected and it is drained into the inferior mesenteric vein. This is the inferior mesenteric vein here. And from the inferior mesenteric vein, it is further drained into the portal venous system around the liver. So this goes into the portal venous system. For the middle rectal vein, it is drained into the internal iliac vein. This is the internal iliac vein, which will also further drain into the common iliac, and this will be drained further into the inferior vena cava. That is the systemic venous network. Then for the inferior rectal vein, it is drained into the internal pudendal vein. This is the internal pudendal vein. From the internal pudendal vein, it is then drained into the internal iliac vein. From the internal iliac, it will join with the external iliac to form the common iliac. And from the common iliac vein, it is finally drained into the inferior vena cava. And that is the systemic venous network. So you can see that the superior rectal vein drains into the portal venous system, while the middle and the inferior rectal veins will drain into the systemic venous system. So you can see that they are drained into different venous systems. So talking about the lymphatics, the lymphatic drainage of the rectum, the upper part of the rectum is drained into the preaortic lymph nodes, while the lower part of the rectum is drained into the internal iliac lymph nodes. For the sympathetic innervation, we have L1 and L2 spinal segments. And for the parasympathetic innervation, we have the S2 to S4 spinal segment. So going to the applied or clinical anatomy, we have the rectal examination. The rectal examination is a process of inserting a lubricated or gloved finger into the rectum, lubricated to allow for easy access and gloved for protection. And this is done where we have rectal bleeding, rectal carcinoma, when you have constipation, when there is hemorrhoids. Urinary problem can also call for this examination, and when there is a need also for us to assess the prostate, maybe to check for tumor or cancer. Hemorrhoids. Hemorrhoids are abnormal swollen veins seen in the lower part of the rectum or the anal canal. And this will develop when the veins are pressured. And what will lead to this pressure include chronic diarrhea or constipation, when one is overweight, pregnancy, or anal intercourse can impart pressure on the venous network of the rectum, and this will lead to abnormal swelling or enlargement of the veins. This can cause discomfort or bleeding depending on the intensity. Hemorrhoids can occur in first, second, third, or fourth degree. For the first degree hemorrhoids, the enlarged veins are seen to be contained within the lumen of the rectum or the anal canal. They are not seen to protrude to the outside. But for the second degree hemorrhoids, the enlarged or swollen veins are seen to protrude to the outside during bowel movements, but they tend to return back into the lumen of the rectum or the anal canal on their own. While the third degree hemorrhoids are also seen to protrude out of the body during bowel movements and are not seen to return back on their own, except when manually pushed into the rectum or the anal canal. For the last degree, which is the fourth degree type of hemorrhoids, they're always seen to protrude out of the rectum and the anal canal at all times. So we can check our understanding of this lecture through the following questions. And the first one is, the rectum is a curved tube seen with a number of curves. Kindly discuss this. The second question will be to highlight the anterior relations of the rectum in both the male and the female. We've tried to explain this in details in the course of this lecture, and we've stated that the anterior relations of the rectum in both the male and the female are different because of the peculiarity of the reproductive system. And the third question is, what is retrorectal or the presacral space? We'll also try to explain this during the course of this lecture. And the last one is to describe the blood supply of the rectum. Thanks for watching.